And thank you for coming to listen to our Reducing Transmission of MRSA and MDRI Infection presentation. Now, this was done with the help of Michael, Miss Diana, and myself, Erin. A little bit of background here. So, healthcare associated infections are incredibly common, unfortunately, affecting about every 1 out of 31 hospitalized patients in the US on any given day. Out of all the possible infections we deal with, MRSA is one of the most common multi-drug resistant organisms, and unfortunately, it's resistant to a majority of typical antibiotics we use, including methicillin and penicillins, among others. MRSA surgical site infections, referred to also as SSIs, increase the length of hospital stays, increase readmission rates, increase treatment costs, and increase morbidity and mortality rates. So not only is this harming the patient, but it's also harming the hospital. So referring specifically to our case study, we've had a dramatic increase in infection rates over the past several years. Now, what are we defining this as? So this is any patient who underwent surgery in our facility, was discharged, and then returned within 60 days with a confirmed MRSA positive culture, regardless of whether or not it was at the surgical site itself, in the bloodstream, or anywhere else on the body. So some analysis revealed to us that it is a combination of causative factors leading up to this, including pre-operative and within the operative environment itself, the patient, the individual procedure being done, education and training of staff and patients alike, the health team, and data monitoring and documentation. We were able to break this into 5 main domains to further analyze, including people, environment, materials, methods, and equipment. If you will look to the right of this presentation, I included some photos to show MRSA, and the top photo is in an infected abdominal wound. The bottom one is MRSA at a skin graft site over the leg. Just a little visual reference. So breaking it down again, people. This includes staff training, adherence to evidence-based practice, improved handoff communication, appropriate staffing, and appropriate workloads, helping to ensure that we're preventing work burnout if possible, and having a realistic expectation between staffing and the patients. Environment, including sterile surgical suites, adequate disinfection of high-touch surfaces, and make sure that we're using MRSA effective disinfectants so that it's actually doing what we need it to do. Materials including chlorhexidine favored over betadine, having PPE on hand, and wound care materials available as well. Methods include updating standardized protocol, patient screening, proper wound care and audits, and equipment having consistent cleaning of reusable equipment, and when that's not available, having disposable or single-use options so that we're not sharing items that can't be wiped down thoroughly, and also making sure that we have sterile tools in the OR. So how do we get there? How do we solve our problem? Well, we must fill in the gaps to align with CDC and WHO standards, including the standardization of processes throughout the facility, using evidence-based MRSA prevention bundle, and utilizing performance audits to ensure that there is compliance and we are doing it correctly here. So together as a group, we came up with a goal to reduce MRSA infections by at least 50% over the next 12 months, and consequently improving patient outcomes across our surgical services. All right, so we have a bare bones plan, but how are we going to get there? Well, we came up with an action plan to break it down into some realistic goals that we can work on as a group. So, the first one is implementation of preoperative MRSA screening. This is to be done within 72 hours of surgery, and it helps us identify early on if there is MRSA colonization of a patient. This allows us to have infection control measures and treatment set up prior to the surgery. and therefore helps reduce incidence of surgical site infections. This is measured through documentation audits with a goal of 100% screening compliance for all patients. Another method we're utilizing is standardized decolonization protocols. If someone tests MRSA positive prior to the procedure, they are to follow a 5-day regimen of medicated ointment and chlorhexidine body washes, making sure that staff are adequately trained and trained well enough so that they are performing patient education satisfactory. And then this will be checked with documentation audits as well against the screening results with the goal of 100% compliance. We are enhancing our surgical skin preparation, including CHG showers for 2 consecutive days prior to surgery, looking at our intraoperative skin prep protocol to use CHG solutions rather than betadine, and utilizing checklists and patient education logs, which we can audit to ensure that we are completing this. Optimization of antibiotic prophylaxis. MRSA targeting antibiotics should be used sparingly based on screening results and with appropriate timing of administration prior to surgery. We can look at this through pharmacy records, surgical timeout documentation audits, and we want to have a goal of 100% compliance. We're also going to standardize the post-operative wound care, utilizing evidence-based practice updates in our protocol with staff training. Wound care checklists will be available. We will also make sure that all wound care orders are up to date, done through with documentation audits. We're also going to enhance surveillance and reporting. EHR audits and infection control dashboards are available to monitor rates of incidence, including post-discharge infections and trends, so that everyone can see patterns. Regular reporting to Infection Prevention Committee allows us to have real-time data and transparency throughout the facility. We also need staff education and training. This will be completed quarterly for surgical and post-op staff who interact with the patient. We'll utilize competency-based checklists to evaluate learning outcomes and support practice changes as needed. This helps to promote a culture of safety and accountability. Thank you for taking the time to listen to our presentation. I hope you were able to learn something today. And if you're interested, we'll be coming out with the QI paper shortly. Thank you.